Good morning. Just move this up. I'm really excited to be here. Thank you to the MS Society for the invitation to speak and share with you this day. And it's really great to see some familiar faces in the audience. So get started. So a couple of disclosures. These are the research funders that have supported our work, and I do get involved with industry-sponsored educational opportunities. The other disclosure I'd like to make today is I am going to talk about aging. So if anybody doesn't want to talk about getting older, then I won't be offended if you're feeling youthful today and you feel that you don't want to hear about that. So my daughter gave me a very hard time for the photo in the program because it's about 15 years old. So I told her, well, I'm just combating aging, honey. So today I was asked to talk about some strategies in MS rehabilitation, and that's actually quite a big topic. So I'm going to focus on defining a little bit what restorative and preventative and compensatory strategies mean. It can mean different things to different people. I'm going to focus on talking about exercise as an intervention, and also just touch on some strategies that involve technology. I'll just briefly talk about where you can access rehabilitation services and outline some future goals related to that. So exercise is a rehabilitation intervention. So exercise can be a restorative intervention, in other words, helping to recover from function loss after a relapse. It can also be preventative, and we don't always think about it this way in MS, but if you build up your reserve, whether it be your cognitive reserve or your physical reserve or even your bone density through exercise, then you will be in a better place as you age with MS. So it's important to understand, I think, when we talk about exercise as an intervention for MS, in terms of what it has been proven to do and not do. So it is clearly associated with improved fitness and mobility, with increased confidence to be active, with less anxiety, with less pain, and it is maybe helpful in reducing fatigue, depressive symptoms, helping with bowel and bladder symptoms, and with cognition. And you heard earlier this morning about the trial going on with Dr. Anthony Feinstein looking at exercise combined with cognitive training to improve cognition in MS. And exercise does not eliminate MS symptoms. So I think it's really important to acknowledge that, because if you're of the mindset that all your symptoms are going to go away if you are only adherent to exercise, that is not true. The bigger question is, can exercise impact MS disability progression? And this is where I'm going to talk a little bit about aging and disability progression. So 60% of people do, in fact, return to their baseline after a relapse, and that is more true with early relapses. And so is there any way that we can improve that percent to greater than 60%? What role might exercise have in that? And unfortunately, disability does occur in the majority of people as they age with MS. And again, we're not exactly sure what role exercise might have in delaying that progression. We do know that walking speed decreases over time when you live with MS. And this is just a snapshot of a study that showed that 20% of people experience a 20% decrease in the speed of their walking over about 6 months on the Time 25-foot walk test. And we like to think that it makes a big difference what type of MS you have, and these are curves from different types of MS. Clinically isolated syndrome, relapsing remitting MS, primary progressive MS, and secondary progressive MS. And the gray is the individual variability, the difference that you see in these different cohorts of people. And there's a lot of overlap. And it doesn't seem to matter what label you're given. It can affect everybody. And this is a classic study that looks at the natural history of MS progression. And again, as you heard this morning, there's an objective to dig a little deeper into what this progression looks like at a finer level. But at a very gross level, if you look at the time to needing a cane in MS and the time until you cannot walk 10 meters even with a cane, it is longer for relapsing remitting MS, and primary progressive MS, it's much shorter. But there's, of course, a lot of individual variability. So this is just at a group level from one old study from 2000. And what's interesting, though, I think, is that the time between needing a cane and the time between not being able to walk is relatively much tighter between relapsing remitting MS and primary progressive MS. So once you need a cane, the time to not needing that cane, it matters less what disease course you started with. And the question is, can we make that time longer? Can we make all these time points longer? So multiple sclerosis, as you know, is an autoimmune disease that involves myelin and oligochondrocyte and neuronal and axonal loss. So not just the myelin is involved, but also the axon underneath. And what we really would like to know is, beyond the disease-modifying therapies that we hope have a difference in long-term impact on disability, can health behavior such as exercise as a rehabilitation strategy also have an influence? So we know that exercise is helpful in the general population in terms of living longer. So it clearly does combat aging to a certain extent. So if in the general population, if you walk only 150 minutes daily with brisk walking, then you can expect to live on average 3.5 to 4.5 years longer. So surely this should be true in MS. So how does it do that? And we don't fully understand how, but one of the things we do know is that physical activity decreases your risk of vascular disease. And if you have vascular disease and MS, you need a cane about 6 years earlier. So there's perhaps an interaction happening there. And there's an emerging body of evidence looking at how exercise might actually affect the underlying pathophysiology of MS. In animal studies, it shows that exercise can help reduce some of the inflammatory markers that lead to new MS lesions or attacks. Animal studies have also shown that exercise can help enhance remyelination after there's been demyelination in animal models of MS. And we know that the central nervous system is able to remodel neuroplasticity, sometimes we hear this term, and reorganize and develop more efficient ways of carrying out motor skills or cognitive skills with practice. So how much is enough to reap these benefits? And nobody has all the time in the world. And so what is enough? Well, we don't know, but in the stroke literature, it appears that high-dose training, so repetitive a lot, is not necessarily better than standard care. And there's a bit of controversy over this, but it's possible that we might be able to reap the benefits of exercise with not as much as we once thought. We don't know the ideal dose. Higher doses also might not always be tolerated. And what we do know is that you have to do some. And the evidence suggests that we need structure to keep doing it. And so if you look at people living with MS and you look at their maximum VO2, which is a measure of fitness, it appears that people who are on a structured program do much better at maintaining their fitness. The other question besides dose is what kind of exercise is most beneficial? And it turns out that it might not matter as much as we thought what type of exercise. So this is a meta-analysis looking at all types of different exercise, from yoga to walking to aquasize, a whole bunch of different interventions. And all of them are beneficial in terms of improving walking speed in MS in the short term. And the greatest benefits were seen with programs that combined aerobic and resistance training. We do have exercise guidelines for the general population, and we do have exercise guidelines that are made from the best evidence possible for MS. And in the general population, this is the 150 minutes a week I spoke to earlier. And in MS, this is 2 times 30 minutes of aerobic exercise twice a week, combined with that strength training twice a week, built on the evidence that the aerobic combined with the strength training seems to have the greatest effect. So this is a busy slide, but one of the questions we asked was, well, what are people in Saskatchewan in MS, living with MS, doing in terms of exercise? And thank you for those of you who participated in this study and filled out the survey. And what we learned was that, in fact, about a quarter of people are doing very well. They're exercising, meeting generally those targets, but unfortunately about 60% of people living with MS are experiencing barriers to meeting that target. So they're not sufficiently active to reap at least those health benefits that we know exist with exercise, and possibly also help with disease progression. And it's not easy. People told us it's not easy. And I'll let you read these. And so in response to this need for to improve and to help, we in Saskatchewan were fortunate enough to get some funding from the MS Society to do 2 different wellness projects looking at exercise as an intervention for MS. And this, some of you might have been a part of. Anybody part of this study here today? Pilates study? A few hands, thank you. So this was a wonderful partnership led by Charity Evans and team, looking at Pilates as a means of exercise for MS, and the results, not surprisingly, were positive and led to now a partnership, an ongoing partnership with Lead Pilates to be able to access Lead Pilates as an exercise intervention for people with MS in Saskatoon. And the other study we did is a web-based intervention with physiotherapists providing home programs that could be monitored through a web-based platform. And this study involved people with all different stages of MS. And I think some of you here today, Rob is here. He was part of our research team for this study. Thank you, Rob. And so it was a journey doing this study because it was a fairly new platform that required some modernization. And we took people who self-reported not exercising at least 2 times a week, so they really were struggling to find a routine. And over half of them exercised twice a week using the web-based platform for the duration of the study, which was 26 weeks long. So in terms of exercise science and changing exercise behavior, this was a success. But it was interesting, we didn't actually see a huge difference between the people who used the platform versus people who just got a paper handout from a physiotherapist in the whole group. But the people who were non-ambulatory seemed to use the web-based platform much more enthusiastically. So this sort of made us scratch our heads and think, okay, well, clearly there's not one thing that's for everybody. Everybody needs a different approach to stay active living with MS. And this is just a screenshot of what the web-based platform looks like. So this led to a study called Individualized Physiotherapy and Activity Coaching in MS. And we were fortunate enough this fall to start the study funded by the Saskatchewan Health Research Foundation and the Saskatchewan Centre for Patient-Orientated Research. And what we really wanted was to study an investment in the long term, because all the exercise studies are fairly short, and that's no good because you live with MS for a long time. So we wanted to assign each person a coach, a physiotherapist coach, and that physiotherapist with the person with MS would do an individualized assessment on what kind of program or routine is best for that person and be their coach for a year. We actually Dr. Donkers, my co-investigator on this, just texted me this morning that we need 5 more people. So there was great interest in this study. We wanted to enroll 120, and we're at 115. 60 people get no coach, unfortunately, for the first year, and 60 get a coach, and then the 60 that have no coach cross over and get a coach for another 6 months. And if we're able to secure funding, we'd like to keep this going and test it as a model of care. So this is what it looks like. You get a physical activity prescription. You get support from a neurophysiotherapist who has experience in working with people with MS, and hopefully change behavior. And we'll see how it goes. I can't even get my son to put his shoes in the hall closet. So it's always, behavior is very difficult. If you go to the MS Society website, you will find the Canadian Exercise Guidelines. You will find a Get Fit toolkit, and I think it's really wonderful that it's there, and it's completely understandable if a person needs more help to keep going with exercise. So exercise can be restorative, it can be preventative, and then I just want to touch a little bit more on this idea of compensatory approaches. So you may need to employ compensatory approaches when you're trying to exercise with MS, and I probably should say you will need to, and everybody does as they age, need to adjust how we move, and that's even more so the case if you're living with MS. So these are just a few examples of how you might have to modify your approach. There is a really wonderful program launched by the National MS Society called Free from Falls. And if you have had a fall, I would recommend this site. It's really well put together. And it's really difficult to exercise if you're thinking at any moment you need the bathroom, or your spasms are not controlled in a way that allow you to move in the way that you'd like to. So I think it's relevant to optimize your MS symptoms even before you get engaged in exercise. And the MS Society of Canada website does a really good job reviewing MS symptoms and all the different treatments. I think also in terms of thinking about exercise, our whole concept about what it is might need to change. So this is from the UK website, MS Trust website. So in fact, we can just do this now because you've all been sitting all morning. So you can put your hands up in the air. And then, great, that's a lot of hands. That's good. And now just lean over the table in front of you if you can, but don't touch that table, don't touch it. Now lean forward as far as you can over that table without falling, and just hold that and take a big breath and then go back again. So that is exercise. I think possibly core exercise strength exercise that focuses on core strength is one of the most important exercise interventions for people with MS, because your core strength is what allows you to sit independently and get from sit to standing independently. If you don't have core strength, you can't do those sit to stand transfers, and it takes core strength to walk and avoid falls. So core strength, I think, is really, really important. This is just so simple. It doesn't cost any money, it hardly takes any time, and it's working your core. So there are some kind of myths that I would like to dispel about compensatory rehabilitation strategies. So first is that a compensating strategy does not make you weaker. So there's this idea that if you, use a brace or do the exercise in lying instead of standing, that you're going to somehow be weaker. You might as well not do it at all. In fact, compensatory strategies allow you to continue to participate in activities, and it allows a faster return to independence. And we know this from the stroke literature, that if you use compensatory strategies, you leave the hospital sooner. So it's okay to do things differently. And the other thing is this idea, in the stroke literature, there's sometimes a bit of a competition. Which strategy should we employ? Well, in MS, I think we can be smarter than that. I think we can do them all at once. So you can use compensatory strategies while you're still building up bone mass and cardiorespiratory reserve, and you can also restore lost strength. You can do them all at the same time. So when you talk to rehabilitation specialists about compensatory mechanisms, you might end up looking at a slide like this one. So this is a study looking at compensatory strategies in very early MS. So these are people that are even not yet quite diagnosed with MS, clinically isolated syndrome, and this is a functional MRI study. And the top panel, A, is looking at healthy controls, and the bottom panel, B, is looking at people with MS, and they were asked to do a cognitive task. And even though both groups could do the task equally well, because these were people with very early MS, not yet experiencing impairments. The people that were doing the task with MS employed more cognitive pathways to do the same task. They used more of their frontal cortex to do the same task. So even though the outcome was the same, they were recruiting more pathways to execute the task, which might explain why people get tired more easily. But it also demonstrates how early people living with MS bring in compensatory approaches to get the job done. So as a physiatrist, when I think about compensatory approaches, I also think about the use of mobility aids to get the job done more easily and to allow a person to walk longer or move further than they would have been able to do so without that mobility aid. And I think in Saskatchewan, when I talk to my colleagues across the rest of Canada, we're really lucky in that we have a fairly good funding program in Saskatchewan for equipment. So you can get braces funded, you can get power chairs funded, you can't get scooters funded through the government, but we do have a fairly good program for accessing equipment. You just need to know how to access it. Again, just evolving technology all the time about lighter braces, easier to use, more cosmetically acceptable. And again, just some misconceptions and what the research tells us about using aids. So specifically bracing. So an ankle foot orthosis can reduce the energy cost of walking. So it can help with reducing fatigue levels, which is a big issue often. The benefit for actually improving walking speed is inconsistent, so people don't necessarily walk faster with a brace. And when you're walking, some people feel more off balance, partly perhaps because some of the brace goes under the foot and you lose proprioception. Some of the newer bracing technology that lifts the foot from the top, you don't lose that proprioception. And I already mentioned that we have fairly good coverage. There is functional electrical stimulation for foot drop in terms of bracing, and it is covered by the Saskatchewan government now. It took a while, but it is covered. And so this works by, I've given you a picture of the lower leg there, but you can see a nerve on the side of the leg. Let me see if I can get the perineal nerve. Does this work? That's okay. All right, we'll just keep going. Anyway, the electrical stimulation hits that nerve, which then stimulates the muscles that pick up the foot so that your toes don't catch when you walk. And theoretically, it should work very well. But you have to be able to tolerate the impulse over the nerve, and it has to be directly positioned properly over the nerve to work properly. And I come up? Okay. And so the other question is this better than another type of brace to lift up the foot? And So sometimes the best information is in the very oldest research. So this is a study, it's now 10 years old, from 2009, and the reason why I like it is because they compared an FES foot brace with an exercise intervention. So one group got the brace with the stimulation, and one group was just given a prescription of a home exercise program involving strength training of the lower extremity and walking. And this is a bit of a busy slide, but the bottom line is that in MS, as I mentioned at the beginning of the talk, usually over time, walking speed decreases. And again, with the exercise intervention, walking speed increased over the 18 weeks, whereas those that just got the brace without the exercise, their walking speed stayed the same, actually got a little bit slower when the stimulation wasn't turned on. So part of the effectiveness of intervention with bracing is potentially explained by the fact that people just walk more when they have the right tool. And if you walk more, then your walking is maintained for longer. So moving into some other technology advances to help keep people moving. So at City Hospital, we do have a functional electrical stimulated cycling machine, and we do have body weight supported treadmill walking equipment. This equipment we use for all types of people with neurological injury, and it can be very helpful. The thing is that if we look at the literature compared to walking alone, it's not necessarily superior. So if you're still able to walk, functional electrical stimulation or body weight supported treadmill walking isn't superior to just walking. The other thing that involves technology is computerized cognitive training platforms, and there's been quite a growth in this area in the last 10 years. And the evidence suggests that these cognitive training platforms do help improve cognition in terms of attention and processing speed in MS. It's not clear, though, whether those improvements are transferable outside the game. So you get better at the game, but it's not clear if you get better in life at remembering which kid you're supposed to drop off where, and all the other things that you need to remember. So that needs to be sort of worked through a little bit more. The other thing that we know is that virtual reality training platforms are also helpful for improving balance, so like the Wii, but they're not necessarily better than conventional training platforms for improving balance. So there's also been some interest in transcranial magnetic stimulation and transcranial direct current stimulation. And these are just ways to stimulate the cortex or inhibit the cortex in a way to hopefully maintain function or enhance repair. And this has really not been proven in MS as an effective treatment to date. I'm still hopeful for TMS, perhaps, based on some animal studies looking at the animal model of MS. But it hasn't been borne out yet in clinical practice. And this is, again, very new technology. So this was just published in the International Journal of MS Care. This is an anti-gravity treadmill walking machine. So instead of being suspended, body weight supported, like the picture I showed you a few slides ago, this one actually pushes positive pressure air from the bottom. So like an anti-gravity effect, like you're on the moon. And then the other slide there are exoskeletons. So these exoskeletons are battery powered to move the limb. So these are very costly and cumbersome and really just still in their feasibility assessment phases. So with things changing so quickly in some ways and so slowly in other ways, one of the things that from across Canada, people working in MS rehab identified was that there is no one place where a person can go to get all the rehab information in MS. And in fact, this has been done for stroke and acquired brain injury and spinal cord injury. We have evidence-based review websites that guide treatment and help with training new people working in the field, but we have no such thing for rehab in MS. So my colleague Tanya Bruno in Toronto, through the Barford Foundation at the University of Toronto Rehab Institute, they were fortunate enough to receive a donation to help support the creation of systematic review of rehab in MS. And it's been a big project, actually, but we're pleased to say that the first 2 chapters just went live, msbest.rehab.ca. It is aimed at professionals, but we hope the long-term vision would be to create practice guidelines and also patient supported platform of information. So the first chapter we looked at was team-based rehab, so this concept of a multidisciplinary team to meet a person's needs with MS, and that's another talk that I'll do another time, but it's really important, I think, that the research that's being done is assimilated in one place and shared so we can move forward. So as you all know, Saskatchewan has among the highest prevalence of MS in the world, and we have Dr. Hayter here in the audience. Where is he? Dr. Hayter, please raise your hand. So Dr. Hayter did the first study looking at the prevalence of MS just in Saskatoon, not the whole province, but in Saskatoon, and that was back in 2007 that he published that. And very recently, Dr. Evans and her team published a new updated rate for the whole province, and we still, unfortunately, are among the highest in the world, and I hope one day to stand up here and say that we are the lowest in the world. But I think what that means to me is that we have an opportunity to have every person with MS have timely access to rehab services and see whether or not that can help improve outcomes in people living with MS. So in terms of information, in terms of managing MS symptoms, in order to better live with MS and stay active, like I said, the MS Society of Canada does a really good job with this. And locally, Shirley McGowan, the MS program nurse educator, you do not need a referral, so if you're not sure how to link with a service, she can help with navigation. And we hope coming soon is the Saskatchewan MS Care Pathway that will help navigate people to resources that they might need. So just to review, rehabilitation approaches can be restorative, preventative, and compensatory, and you can engage all 3 at the same time or over the course of your week. Exercise is an accessible intervention, and I don't think we should be hard on ourselves because everybody needs support and structure to maintain participation. And technology has its place, but to date, really, we haven't seen technology that is better than conventional exercise or standard simple prescriptions. And we have very good funding for equipment. We do need to improve access in terms of people power for rehab services. And I'd like to thank everybody here who's volunteered for research. We couldn't do this without you. And my daughter did the MS bike this year, so she's the one in the orange shirt, so I was very proud of her for doing that. And thank you to all of you who have raised money or participated in some way towards the cause.
Yes, I was just wondering if, with that AFO, if it makes any difference if you're wearing a heeled boot or if you just have flat shoes. And
Okay.
oh, go ahead.
Where's I can't see the person. Okay. Yes, so it can make a difference what type of shoe you're wearing, for sure. It can affect how the knee behaves, whether you're wearing a heeled shoe or a flat foot, in terms of whether or not you have weakness at the knee, so, and also at the ankle. So it depends a little bit on you, what's best for you in terms of where your weakness is. But it would affect your gait, what footwear you decide to wear with the AFO.
Okay, and I was also wondering with that FES, I had the Bioness a few years ago, and I was wondering if they made any improvements in that patch that gets put on your leg.
Yep.
Because that would break down the skin. I quit using it because it broke the skin down so bad, and I was just wondering if there's any improvements in that.
I don't know about the Bioness product specifically improvements. It is a known problem that people have skin irritation, and so a certain percent of people just cannot tolerate wearing the brace for that reason. I don't know offhand if there's been changes to it, but we could certainly find out. I would recommend talking to the people at the Abilities Council if they've come out with any new adhesion material for that. Yep.
Hi, thank you very much. It's Deb. How do people sign up for those 5 spots in that physiotherapy study, and what are the criteria for that?
Sure. So for this one, we are looking at ambulators, and we hope to expand it. So you can just email ipacms100@gmail.com, and we will get back to you. So you just need to be able to walk, and you can't be an over-exercised keener to start with, because we're targeting people who need a coach or who might benefit from a coach. So yeah, that's ipacms100@gmail.com.
Are there, just a follow-up question, are there physiotherapists that are available to help a person develop their own home physio program?
Yep.
That could be used in your own,
Yes.
fitness room in your condo like we live
Yes.
in now?
Yes, there are. So the wait time is fairly long, but you can ask for a referral to Rehab Day Services if you want to go through the public system at Saskatoon City Hospital, or through Rehab Day Services in the south, Wascana, and ask for home exercise and mobility program, and see a physio. So the thing is that these programs are there's time restraints, so they'll only see you for so many weeks, and then you have to get a re-referral. They don't keep you forever, which is just to be managing the wait list. It's not a patient-friendly chronic disease model of care, in my opinion. But you can do that, and you can also seek privately physiotherapy input. It doesn't necessarily need to be a physiotherapist either. You could seek out somebody who has, an exercise trainer who has interest in MS, and the MS Society has some programming where they have some experienced exercise trainers. So yeah, good question. Thank you. Do you have any other suggestions? You've been in the system a long time. No? Okay. Sorry. I didn't mean to put you on the spot. Yeah.
It's not a question. I've just been involved in some of your studies, and I wanted to say your staff has been absolutely amazing, and I just want to tell you how much we appreciate everything you're doing for all of us, because it's nice to know there's somebody out there helping to figure out how we can be guided through this whole MS mess. So thank you.
Thank you. I really appreciate that. I'd like to acknowledge Beth Brimner, who's one of my staff. Beth, can you stand up? Come on. She doesn't like this, but Beth is with the MS Drugs Research Program and helping a lot with recruiting for different studies. So thank you for mentioning the staff. I really appreciate that. Any other questions?
This is a comment. In one of the recent MS newsletters, there was reference to Trevor Wicken and the MS Geom
Yes.
and links to his, and I've just started looking at that. It looks like an absolutely wonderful site and program.
Yes, thank you for bringing that up. So I signed up just to learn about it, and I think it's a great program. And the only thing is that there is a cost to it. Like you can do the cost-free version, or you can do the cost. So I didn't try out the cost version, so I can't speak to that. But you know, the idea of providing ongoing support in a community of people that are up against the same challenges is wonderful. And from what I can see, he's informed and knowledgeable about the challenges that people with MS face. So I think it's wonderful. If that's working for you, that's terrific.
If I want to support MS research, MS interventions and supports, should I be contributing to the MS Neuroscience Center here or through the MS Society?
You can do both. There's really no wrong or right answer. I think your dollar goes a long way wherever you put it in MS research, and so you know, both are great, and there's no wrong way if you're donating.